Well, I'm Dr. Vinod Kumar. I'll be talking about dementia and hypoglycemia in elderly diabetics. I will first share my screen for the transparencies. So I hope you can see the slide, and I will put it on the slideshow now. So here we go. So the subject is bidirectional significance of dementia and hypoglycemia in elderly diabetics. I think it's an undisputed fact that diabetes is associated with increasing prevalence of dementia as the age of our population is going up. It is also known that in elderly people, when they are diabetic, they not only have associated dementia, they also have an acute complication of hypoglycemia more frequently than what is seen in younger diabetic patients. In other words, dementia begets hypoglycemia and hypoglycemia begets dementia, about which I will be talking of a bidirectional relationship with these two conditions. So, with regard to this bidirectional relationship, we will be discussing this subject from three angles. One is mechanism, second is magnitude of the problem, and finally, what is the medical significance of this bidirectional relationship between dementia and hypoglycemia? As far as the general mechanisms of dementia occurring in diabetes is concerned, it is quite well known that high blood sugar, that is hyperglycemia, it generates what is called AGE, that is advanced glycation end products. Oxidative stress goes up. There is an endothelial dysfunction which results in micro and macroangiopathy, which together with general risk factors of dementia like obesity, hypertension, and dyslipidemia, and with insulin resistance, it results finally in cognitive impairment, which can take the shape of either vascular dementia or Alzheimer dementia mostly. Other mechanisms of dementia occurring in elderly persons is inflammation, mitochondrial dysfunction, which results in lesser energy to the brain cells, and therefore the brain cells degenerate and die away. As I said, there is an increased oxidative stress, and there is finally the deposition of amyloid B plaque and neurofibrillary tangles, that NFT thyopathy, which are the hallmarks of Alzheimer's disease. Now, coming to the mechanism how hypoglycemia can lead to dementia through hippocampal loss. Hippocampus, as you know, it is a seat of learning and memory. Once this is affected by low blood sugar, dementia can result. The mechanism is like this: because the low blood glucose, there is a reduced glucose uptake by the brain cells, which otherwise are a source of energy for the brain cells. It also damages the blood brain barrier and generates an inflammatory marker called MMP9. And this all is because of the pericyte damage due to hypoglycemia. And when all this happens, all these conditions give rise to micro, mitochondrial dysfunction, reactive oxygen species generation, and this finally leads to amyloid beta amyloid deposition and tau protein and neuronal cell apoptosis, which together result in loss of hippocampal brain and finally dendrocytes and impaired synaptic plasticity. And this results in Alzheimer's disease, which is the major part of dementia. Of course, the vascular dementia is also accompanied by such a loss. What is the mechanism? How dementia leads to hypoglycemia? There's the other way around. I think it's not a rocket science at all. When somebody has dementia, that means he loses the power of attention, he loses the power of comprehension and judgment and memory. Then what will happen? Once he gets hypoglycemia, he will not be aware of the symptom that he is having, and he would not be able to correct this hypoglycemia quickly due to poor psychomotor performance. Then other factors are again because of dementia, forgetting taking meals or delaying taking the food. Maybe he has taken anti-diabetic drugs twice and have lowered unattentively blood sugar unduly low. He might undergo glucometer and insulin dose errors. There is already a low brain metabolism of glucose with wide glucose level fluctuation, and sometimes the caregiver which is instructing this patient, there may be miscommunication between the two. All this can lead to hypoglycemia in a patient who is already demented. Now, coming to this study is by Kim. They have selected 11,932 patients who were elderly diabetic. This comprised two equally matched subjects. One who never got hypoglycemia during the follow-up of about 4 to 5 years, and the other who had at least one or more episode of hypoglycemia during the same period of follow-up. It was discovered that those patients who they got emerging hypoglycemia in 2,934 patients. And when they were compared amongst hypoglycemic patients versus non-hypoglycemic patients, the HR ratio was in favor of hypoglycemic patients and the p-value was significant. Same was the story with regard to Alzheimer's disease type and the vascular dementia type. In both of these conditions separately also, patients who had experienced hypoglycemia had more frequent emerging incidents of dementia compared to those patients who never had experienced hypoglycemia among the elderly diabetic. The same results have been shown on the basis of survival analysis curve shown in this picture. You will find that the upper blue line represents the patients without hypoglycemia and the lower red line indicates the patients with hypoglycemia. You will find right from the beginning of the follow-up, where less than 1 year follow-up, the two lines have started separating, and it is seen that patients without hypoglycemia had a longer dementia-free survival rate compared to patients who had hypoglycemia, who had lesser number of patients with dementia-free survival rate. And that clearly shows once again that patients who are having hypoglycemia or who were having hypoglycemia 1, 2, or 3 episodes, they had more frequent dementia emerging compared to those who never experienced hypoglycemia. When the same study tried to find out the magnitude of dementia risk according to the number of hypoglycemic episodes in patients with and without hypoglycemia, of course, it was only the hypoglycemic patients who were included in this study. As far as the number of hypoglycemic patients is concerned, it was found that those who had only one episode of hypoglycemic episode, as shown on the left side, they had 1,159 emerging dementia risk. And compared to those who did not have hypoglycemia, the p-value was significant. Those who had 2 to 3 episodes of hypoglycemia, they had 550 events, but this was also highly significant between those with hypoglycemia and without hypoglycemia. Finally, those who had more than 3 episodes of hypoglycemia, when they were compared with patients without hypoglycemia, again the p-value was significant. And in all these 3 cases, hazard ratio favored for those with hypoglycemia in terms of dementia emergence. This is another study by Yeff et al. In 2013. This shows the same thing that on the basis of survival curves in elderly diabetics, but it more clearly shows the directional relationship. In the upper graph, it is time to dementia associated with a preceding hypoglycemic event. And in the lower graph, it is time to hypoglycemic event associated with a preceding dementia diagnosis. And you will see in both the graphs, the two lines are separating out. In the upper graph, patients with no hypoglycemia represented by the continuous black line had longer dementia-free survival rate compared to patients who had hypoglycemia represented by dotted line who had less number of patients with dementia, who had less number of dementia-free survival rate or dementia. In the lower graph, same thing has been shown, but it is the other way around. Here, it is time to hypoglycemia event associated with a preceding dementia diagnosis. And again, it shows that dementia predisposed to hypoglycemia more frequently than those who did not have hypoglycemia. This is yet another study by Gomez and Gujaro, where it is showing that number of hypoglycemia indeed is related to the risk of dementia, and as the number of hypoglycemic events increased from 0 to 1, 2, and 3, the risk of dementia increased linearly as shown by risk ratio at different periods of different episodes of hypoglycemia. This is yet another study showing the same thing. You kindly confine your attention on the figures between the red lines, and you will find that the total number of patients studied was 1,957. Out of them, 1,839 patients never had any hypoglycemia, and the dementia emerged in this group to the extent of 6.83% of cases. When there was a history of one episode of hypoglycemia in 84 patients, the risk of dementia increased to 10.92%. And when the hypoglycemic rate was more than 2 episodes, then in these 34 patients, the dementia risk increased further to a whopping 36.83%. And this was statistically significant as shown by p-value here. Now, coming to the medical significance of this bidirectional relationship, I think this is responsible for enhanced morbidity and mortality and exorbitant cost due to recurrent hypoglycemia and augmented load of dementia in these patients, which is often associated with hospitalizations, and therefore healthcare provider therefore needs a skill to deal with both disorders in a better way. Namely, both these disorders mean dementia and diabetes in order to prevent hypoglycemia. So what is the medical significance with a focus on dementia? I think elderly diabetics need regular cognitive screening, and whenever found that they have a cognitive impairment, they need cognitive stimulation by self-brain challenging exercises, recollection exercises, stimulation of their senses, and overall social interaction for elderly diabetics. It is also equally important to deal with frailty, malnutrition, polymorphisy, and other declining intrinsic capacity functions if present, and known risk factors of dementia like hypertension, dyslipidemia, obesity, etc. And finally, we all know that exercise is good for brain health, therefore multimodal exercises are important, namely the aerobic exercises, the resistance exercises, the stress exercises, stress stretching, or yoga, etc. Medical significance from the point of view of hypoglycemia is also important. And what is needed? The healthcare providers need health education on continuous glucose monitoring, which may be required in many such patients in old age. And they also need to be educated for various hypoglycemia prevention methods as it is an emergent situation. It is also important for the healthcare provider to simplify, to personalize, and individualize the tailored anti-diabetic treatment depending on the type of elderly diabetic whom they come across. And in this direction, it may be important to relax the glycemic target without falling prey to clinical inertia in clinical practice. So these are the glycemic targets which are recommended for elderly diabetics depending on the degree of cognitive impairment. Please confine your attention again between the red line. If there is no cognitive impairment, target HbA1c is 7 to 7.5% is okay for elderly people. If there is a moderate cognitive impairment, you relax this target to 7.5 to 8.5. And if there is a severe cognitive impairment and dementia, no recommendation of a HbA1c target. Anything more than 8.5 is okay. Thank you. I hope you enjoyed the discussion. Thank you so much. Bye bye.